Welcome to Your Family's Health, the program that focuses on healthcare issues with unique and different modalities for taking charge of your health today. Experts talk weekly with our continuing roster of guests from around the country and right here in Nassau County to keep you up to date on the latest health issues and trends. Take care of your mind, body, and soul. Spend the next half hour with the voice of Nassau Community College, 90.3 WHPC, and get on the journey to better health.
Hello and welcome to Your Family's Health. My name is Dr. Jeanine Cook-Garard from the nursing department here at Nassau Community College, and today we're going to learn about hernias, what they are, and all about the surgeries to fix them. Our guest today is Dr. Michael Grieco, a surgeon and the program director of the Centers of Excellence in Hernia Surgery at Glen Cove Hospital, which is a part of Northwell Health. Dr. Grieco, welcome to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC. Welcome.
Thank you. Thank you for inviting me.
So first of all, I hope you're doing okay in light of the pandemic. Has the virus affected you personally?
No, not personally, but with the past year, it's been kind of strange, especially at the beginning. All the hospitals inundated with patients who are positive, and it was pretty rough for a while, but we all got through it. The nurses did a great job, and the doctors also.
Tell us a little bit about you and your career path and what brought you to Glen Cove Hospital.
Well, actually, I grew up in Glen Cove. In fact, the two surgeons I joined in private practice 40 years ago had taken out my appendix when I was 8 years old.
Wow.
Little did they know. But I traveled in various states. I did my basic training, residency, 5 years at North Shore and Manhasset, did a 1-year fellowship in gastrointestinal surgery in Boston at the Leahy Clinic, and did 1 year of colorectal surgery in Johns Hopkins program. So then I came to Glen Cove, and I've been in Glen Cove for the past 40 years, on staff at other hospitals, but now mostly at Glen Cove.
I love that hospital. So let's start with the basics. What is a hernia?
I looked it up actually in the dictionary just to see what Webster had to say. It's kind of interesting. It was derived from the Greek word hernio. Basically, it's a protrusion of an organ, part of an organ, or other tissue through an abnormal opening in the wall or a cavity that normally contains it. And that's the definition you see in a dictionary. When you go to a medical dictionary, they give kind of a similar definition, but they also list all the different hernias. And Stedman's medical dictionary has listed 76 types of hernias, and Dorland's medical dictionary 111 different types of hernias. But basically, it's an organ that's in a cavity in the body that goes through an abnormal opening in that cavity.
Who can get a hernia? Anybody
can get it, men and women, children. Worldwide, 20 million people are affected yearly. It's 12 times more common to have any kind of hernia in a man than a woman. 75% of all hernias develop in the groin, called inguinal hernias. 90% occur in men, but it can occur in women. And in the United States alone, it's approximately 700,000 operations a year are performed on various types of hernias. So it's very common and can occur in anyone.
So you mentioned inguinal hernias. What are some other very common hernias that you may see in practice?
Well, inguinal hernias are by far and away the most common. They occur in the groin. There are actually two types of groin hernias. The other type is a femoral hernia, which occurs just below the groin. Another common type of hernia is an umbilical hernia, which is right in the middle of the abdomen where the belly button is, called an umbilical area. If somebody has an incision into the abdomen from some previous surgery, you can develop a hernia in that area. That's called an incisional hernia. You can have a hernia from an injury playing sports. It's called a sports hernia. Those are the basic, most common hernias that we see in private practice. They can occur really any place in the abdominal cavity where a hole develops. And as I explained to my patients, we're born with holes in the abdominal cavity. And any place where there's a hole, a piece of intestine can pop out and get stuck. It's basically what a hernia is. And I explain that to them when I come to my office. So again, it's a hole in the abdominal cavity. And those other hernias I mentioned are all different locations for where the holes would be.
So I know that you said there are some holes in the abdominal musculature, right? And so there's like a protrusion of the organ through that hole. What causes the protrusion? I mean, some may have hernias, some may not. What causes the...
Okay. When I explain to my patients very simplistic terms that there are 3 layers of tissue in the body. Skin, of course, on the outside. The second layer is fatty tissue, and the third is called fascia. It's mixed in with the muscle. That's the third layer. It's like that all over the body: arms, legs, chest, and abdomen. And all the organs are behind the fascia in the abdominal cavity. So when you stand, when you sneeze, when you cough, all the organs are pushed out on the back side of the fascia. And if there's a hole in the fascia, a piece of intestine can protrude, and that's what a hernia is. Now, we're born with holes in that fascia. We're born with a hole in the umbilical area. So that usually closes over sometime after birth in most babies. Some people, it remains as a small hole. So that's a hole that's there throughout someone's life in a small percentage of the population. That hole can get bigger with time. At first, it's small. It can get bigger. It can get bigger if you have extra pressure in your abdomen, if you're straining, if you're lifting things, pregnancy causing extra pressure. A number of things can do that, even constipation. Anything that puts pressure in the abdomen pushes on that hole. And if the hole is now big enough and over time it can get stretched out, the intestine can pop through. So that's a hole that people have sometimes at birth. In the groin areas, where the most common hernias are, the inguinal hernias, everybody has a hole there, both men and women. And in fact, some babies are born with large holes, so that at birth they have hernias on both sides where the intestine pops out. We don't do anything at that point. We usually wait at least 3 to 5 years because the baby grows, the intestines grow, and the opening remains the same size, so they no longer have a hernia. But if they still have hernias on both sides at about age 3 to 5, then we do fix them. Many people are born with openings in both groins, but it's made out of thin, weak tissue. That's just the way they are. It's genetic. It tends to run in families. So that later in life, either in somebody who does a lot of straining and pushing, playing a lot of sports, have constipation, or just somebody's getting older and the tissue's getting thinner and weaker as you get older, that opening that everyone has at birth in the groin gets bigger and bigger and bigger. Now they get to the point where the intestine can come out. Now, it may be a gradual thing that they don't even notice, or it can be sudden with a lot of straining or pushing and they lift something suddenly. So it's not always lifting that does it. It can happen to anybody just out of the blue. They notice it.
So tell me, how does one know that they have it? What are some of the signs and symptoms of a hernia?
Oh, it's interesting. The most common story I get in my office is that someone is taking a shower and all of a sudden they look down and they feel a lump in the groin. Again, the inguinal hernias are the most common by far. They feel a lump and wondering what that is. Then they end up coming to the doctor's office and they found out it's a hernia. That type of situation where there's a lump there, they're not even aware of. That lump, as I mentioned, has always been there. That hole's been there. But now the intestine is protruding enough they can feel it. But it may be totally without symptoms. They may not feel it at all. Some people are walking around or active and they start feeling a discomfort in their groin area. They're not aware that there's a lump there. They don't know that there's any difference unless they put their hand there. So they end up going to a doctor's office to get examined, explaining that they have a groin pain. The doctor examines them, either feels the lump or puts a finger in the groin on top of the skin and asks them to cough. And if they cough and the opening's big enough, the intestine will pop out. The doctor says, you have a hernia. Now, those are the two most common ways. Somebody finds a lump, they feel it, especially when showering. I hear that all the time. Or they feel some discomfort. Those are the two most common ways. Somebody can strain and push and get a severe pain in the groin, but if they don't feel a lump, it's usually unlikely it's a hernia. So if you have a severe pain and you don't feel a lump, it's usually a muscular strain, but you still need to be examined by your physician. That's the most common times. There are other times when a hernia is found. Somebody has some vague complaints, especially in the abdominal area. They end up being sent for a CT scan of the abdomen, and the report comes back, everything's okay, except it's reported that they have bilateral, meaning both sides, inguinal hernias containing fat, and or they can have a umbilical hernia containing fat. That those are something that patient may be totally unaware of and not be symptomatic from. And even during a physical examination, it may not be found during a physical examination by their doctor. But these are hernias that are potential sites that can be a problem. But as long as there's fat in the hernias and no bowel stuck, should not be a problem. They don't have to have surgery.
So tell me, outside of the physical examination, how a hernia is diagnosed? It's
usually just physical examination. Okay. Patients will ask me all the time, well, okay, you say I have a hernia. Don't I get an x-ray? It can be done. But if we're going to do an x-ray, that's when we're not too sure of the diagnosis. And there are certain things that can mimic hernias. And if we're not sure that that lump we're feeling is a hernia, for instance, a hernia should, most of the times, when you lie down, it should go back inside. You stand up, it comes out. You ask a patient to cough, it pops out through that hole that's in the abdominal sac. But if those things are not classic, even though it's in the right place, sometimes you need to have a CT scan. That can be done. A sonogram can be done, but usually a CT scan. But we're usually doing that to make sure nothing else is going on. Some people have trauma and they get a swelling in the groin. It may just be blood under the skin, which is you get a pocket of blood. It can form a lump, and that's called a hematoma. There are some rare instances when there are tumors in the abdominal cavity and they manage to work their way to the surface and present in the groin or in the umbilical area or someplace else in the body, and one is wondering if that is indeed a hernia. And as I mentioned before, you can have muscle tears or strain, and they can present as discomfort in the groin and even lumps if the muscle's torn a little bit. One thing also is that people can develop lumps in the groin or elsewhere that feel like fatty growths called lipomas, which are very common. And if it happens to be in an area where an inguinal hernia might be located, it might be a little difficult to tell the difference between the two, to differentiate them. So there are times when we do CT scans, but usually we don't need it. It's done on a physical exam, and we just then discuss with the patient whether or not a hernia has to be fixed or not, and if there are things that can be done other than operating on somebody.
You're listening to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC. My name is Dr. Jeanine Cook-Garard, and today we're learning about hernias and what they are and all about the surgeries to fix them. Our guest today is Dr. Michael Grieco, a surgeon and the program director of the Centers for Excellence in Hernia Surgery at Glen Cove Hospital. Tell me about how hernias can be treated without surgery and then with surgery.
One has to understand that hernias do not heal. When you get a hernia, even if it goes back inside, and the statement is it reduces or it gets pushed back inside, that's not going to heal up. That opening where it came from is always there. It's always a potential site. And there are basically three types of hernias. All the different types I mentioned with different names, but of all of them, there are three general types of hernias. There's the simple hernia, there's the stuck or incarcerated hernia, and there's the strangulated hernia. No matter where the hole is in the abdominal cavity, those are the three types. With a simple hernia, the intestine can pop out and can get stuck there. If it comes out and it goes back and forth without a problem and no pain, and it easily goes back in, it's soft and easily reducible back in the abdominal cavity, that's a simple hernia. We don't have to operate right away. If it gets stuck because too much comes out through the hole, can't go back in, then we recommend fixing that, because if you leave it there like that for a while, the blood to that piece of intestine gets pinched off. It turns into something called a strangulated hernia. The intestine turns black. So for that reason, since a hernia can't be healed up anyway, we recommend surgery in one way or another. Now, your question was, what can you do about hernias if you don't want to operate? And there are some patients you cannot operate. If you have a patient with a lot of medical problems, which means they're usually older. As somebody gets older, they develop medical problems, of course. But there are some younger people that have a lot of medical problems, and they're not good candidates for surgery. But it's not the age, it's the medical condition. And there are just some patients that refuse surgery. So what we tell them, number one, you have to be careful. You have to be careful lifting things. If you're going to lift something, make sure it's very light. If you have to lift something heavy, get someone else to do it. We tell them if you're going to cough or sneeze, you feel it coming on, put your hand over the groin area or wherever the hernia is in the umbilical area. Put your hand there and press so the intestine doesn't tend to pop out. So you have to be very careful what you do activity-wise. The other thing is there have been for many years, contraptions that people can wear that may help out. They're called trusses, corsets, belts. And basically that puts pressure on the area where the hernia pops out through the hole. Now that might give some relief, but it gives you a false sense of security. I've seen people with belts and these types of things on for inguinal hernias, especially older gentlemen or ladies. And then they lift something heavy thinking it's going to prevent the hernia from popping out. Hernia pops out and then it gets stuck or incarcerated. The next thing, it leads to a strangulated hernia, which is a serious problem. So if a patient can tolerate surgery, then the safest thing to do is to fix it. Now, it doesn't, with simple hernias, there are really with the hernias in general, two schools of thought, especially the inguinal hernias, that when you make the diagnosis, you should recommend surgery as long as they're a healthy person. Now, if it's a young person, you might recommend it a little bit more than an older person, because a younger person, as I said, it's not going to heal and go away. So in their lifetime, they're going to need it fixed, so you might as well do it while they're young and healthy. An older person, you might wait. The other school of thought is you can wait for somebody to develop some symptoms and then you recommend surgery. Well, that's okay, but it's generally not a good idea, especially in a younger person who'll need it fixed eventually. So in other words, there is no way to take care of hernias. You can control them and the symptoms, but you can't cause them to heal. You can't get them to heal up. So eventually you need surgery, as long as you can tolerate it and you're good enough shape.
So you mentioned a surgical mesh. Talk to me about the surgical mesh. How is it put in? What is it made of? And, what is the implications that surround this surgical mesh?
Well, it's something that back in the 70s, I hate to date myself, but I was in my surgical training at that point. We were using mesh. It's like a screen. Patients that see the sample I have in the office, they work or they're construction workers. Oh, yeah, that screen I use in my house. That's what it looks like, a screen. There are various types. They're usually some sort of synthetic material, a plastic, various types of plastics that are used. It's very soft and flexible. Back in the 70s, we didn't use it except on very complicated hernias and recurrent hernias that came back. Then getting into the 80s and 90s, we started realizing, well, why don't we just use it on everybody first time around when we fix the hernias? So we routinely use it when we fix hernias. But as I said, back in the 70s, we did it without it. Now, the difference is that back in the 70s, without mesh, the recurrence rate of hernias returning, now we're talking about mostly inguinal hernias, the groin hernias, was about 5 to 7%, which sounds pretty good, but to a surgeon, that's too high. Generally, if you have a piece of mesh when you do the repair, you have a less than 1% chance that the hernia will come back. So that's the big difference. Now, it also allows you to fix the hernia without putting any tension on the tissues inside, because when you fix it without mesh, you have to make that opening in the groin, especially in a man. You can't close up the hole in the man. You can only make it tighter by putting stitches in, or you put the mesh in, and that reinforces the area. And in a lady, we use the mesh too, but we close up the hole with stitches. So the mesh allows us to repair the hernia without putting tension on the tissues, because we're just reinforcing the area rather than closing up the hole to some extent. And it's very safe. If you go on cable late at night on TV, you'll see advertisements from hernias talking about suing because somebody put mesh in. But it's a very safe material to use, and there are different types. There are meshes that are used when there are infections with trauma, and we have to close, say, the abdominal cavity. There are meshes made out of pigs, porcine meshes, all different types of meshes that can dissolve. But the usual mesh in hernia repair is a mesh that does not dissolve. It's made out of plastic. And it makes for a hernia that's much less likely to recur, and there's less pain when you use mesh. Patients think they feel the mesh afterwards, but they don't. It's very safe to use.
So talk to me about how long can I expect my mesh to last? Is it the rest of my life?
The mesh lasts forever. It's permanent. What happens is that since it's a screen, it's done that way on purpose, because scar tissue can grow into the screen, and it makes nice, strong repair. Usually takes 3 to 6 weeks for a good setting of the mesh. We put in with permanent stitches also to keep it in place so it doesn't roll around. But scar tissue grows into it, and usually we recommend to patients anywhere from 3 to 6 weeks, depending on which article you read, that you shouldn't put pressure on the area. So I tell my patients no heavy lifting, pushing, or shoving for about 3 weeks, even though they're feeling pretty well by 3 weeks. But I tell them to take it easy even after 3 weeks. But that gives it some time to set and the scar tissue to grow into it. But it's permanent, and the stitches that keep it in place are usually permanent. Some surgeons put the mesh in with very few sutures. I know a couple of surgeons that don't even use sutures, and they hope that the scar tissue grows into it pretty quickly. But it's permanent.
You're listening to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC. My name is Dr. Jeanine Cook-Garard, and today we're learning about hernias and what they are and all about the surgeries to fix them. Our guest today is Dr. Michael Grieco, a surgeon and the program director of the Center for Excellence in Hernia Surgeries at Glen Cove Hospital. So, Dr. Grieco, one other question about the hernia surgery or hernias in general. You mentioned about hernia belts. When are they appropriate? Where do I find them? Or where are they sold?
Well, you can find them in any drugstore, pharmacy. They have them there. Not everyone probably has them because they're not used very often. But you can contact a pharmacist and they'll probably let you know. They're available. If you also go online, the internet has them. I looked them up the other day, just curious to see what was there. Quite a few different kind of contraptions and even tight underwear, I guess you would say a corset, that can help out somewhat. So it is helpful for some people, those who refuse surgery or for medical reasons cannot tolerate surgery.
So when we talk about high-risk people, who are really predisposed for hernias, what would be the typical clinical scenario for you, someone coming in? Would it be the obese patient? Would it be the older patient? What kind of patients would you suspect are high risk?
You mentioned them, older patients, because as one gets older, you tend to have medical problems, but not necessarily so. People in their 80s and 90s have hernia repairs if they're okay. But if somebody has heart problems or lung problems, diabetes, the medications they're on, they have to be examined by their cardiologist or medical doctor beforehand, who decides what the risk is for surgery. So it's the medical issues. Obesity has a lot to do with it, but even more so after the operation. So that if somebody is very much overweight, the hernias will have a lot of pressure on them if you operate in that scenario. So we tend to tell patients, please lose some weight. When you've lost some significant weight, come back and we'll fix the hernia. This way, there's a better chance it's not going to recur. And people that are overweight with obesity, they tend to have more medical problems also. That adds to it. The other thing is when we decide who are candidates for surgery, it's the type of anesthesia, which I have not mentioned yet. We usually fix the hernias with sedation and then placing a local anesthetic like xylocaine into the skin. And we make small incisions that way. There are other ways to fix hernias that are done. This is, by the way, that's called the open technique with an incision. But hernias can be fixed by what's called closed techniques called laparoscopy. Mm-hmm. We do a lot of laparoscopic surgery in the United States on gallbladders, and some surgeons use them on hernias. Most hernias are done, by the way, I mentioned having a small incision, maybe 2 inches. That's the open tension-free repair. But it can be done by laparoscopy where tubes are put in. However, laparoscopy has to be done with general anesthesia. There are advantages and disadvantages of laparoscopic repair of hernias. But if somebody has severe medical problems and they cannot tolerate general anesthesia, then there's no option. They have to, if they're going to have the hernia repaired, it has to be done with sedation intravenously and local anesthesia. So those are the factors we deal with when speaking with patients about the different types of surgery.
So how long typically does hernia repair take? And can I have my hernia repaired surgically on an outpatient basis?
Well, all hernias are done really on an outpatient basis. When I say all, those are the typical groin hernias, umbilical hernias. The only hernias that are not done on an outpatient basis are very involved, complicated abdominal wall hernias where previous incisions are. And even those we sometimes do as an outpatient basis with general anesthesia. But if somebody has a very complicated surgical history with multiple operations and the incisions in the abdomen have developed multiple large incisional hernias, we try to do it as an ambulatory outpatient setting. but many times patients have to be admitted at least overnight and maybe for a day or two. So the more complicated ones stay overnight, but almost all hernias nowadays are done. Come in the morning, surgery, regular hernias take less than an hour, a couple of hours in the recovery room area, and you go home shortly after that.
So in preparing for this kind of surgery, do I have to not eat before the surgery, or what is the preoperative, usually the rule preoperatively before surgery? Well,
it's like from any operation, you're supposed to stop eating and drinking after midnight. There is no specific preparation, just the warning, don't have anything to drink.
No bowel cleansing or nothing like that prior to?
No, nothing is needed like that. Maybe sometimes the very large abdominal incisional hernias, we like to get the bowel cleaned ahead of time and have the patient on a liquid diet the day before. But usually even that's not necessary. So there is really no preparation other than to fast from midnight on. Sometimes we allow patients to drink until a couple of hours before, and they can take their medication that way if they have to. But generally they're fasting.
So where can people find out more information about you and what you do? Is there a website?
Well, it's there'll be there should be a website now about the Hernia Institute at Glen Cove. You can call the Glen Cove Hospital directly, and there are right now there are 6 surgeons, and we're going to be having more joining us, doing various types, all the types of hernia surgery, including laparoscopic. We're also going to be starting a program in the near future, it looks like, doing robotic surgery on various types of hernias. And that's something that's exciting and going to be brand new. But just call the hospital directly and at Glen Cove Hospital, and you can just ask to speak to someone from the Hernia Institute, and they can direct you to our list of surgeons.
If you had to leave the listening audience with 1 or 2 words, what would they be surrounding hernias and hernia surgery?
Don't wait too long on having a hernia fixed. Go to your doctor, get some advice. I recommend for a lot of people with some of the various illnesses and diseases they have, you can go on the internet, but don't go too crazy on that, because what you'll see about hernias, it's interesting. You can go for hours reading all the advertisements and marketing by various surgeons and hospitals regarding hernias and how their hernia is the best and how it should be done by them and nobody else. And I can't believe how many false information there is on the internet regarding the subject. So you contact your doctor, contact your local hospital, and try to get the real deal that way without going on the internet. I think that's very important.
Well, thank you for being here, Dr. Michael Grieco, a surgeon and program director of the Center of Excellence in Hernia Surgery at Glen Cove Hospital, which is a part of Northwell. We hope you stay safe and continue to stay healthy. And thank you for being our guest today.
Thank you for inviting me.
This is Dr. Jeanine Cook-Garard from the nursing department here at Nassau Community College, and we want to thank you for listening to this week's edition of Your Family's Health.
We'd like to get your feedback on your family's health. Send your comments by emailing them to whpc@ncc.edu. Podcasts of today's show are available on iTunes, Android Podcasts, and Spreaker. This program was produced at the studios of Nassau Community College in cooperation with the nursing department. Join us next week for another edition of Your Family's Health on the voice of Nassau Community College, 90.3 WHPC.